There you go. So welcome everyone to Project Unify meeting, April 20th as 2022. So welcome all to today's call. We probably will have a few people join us as we proceed over the next hour and 15 minutes, hour and a half or so. The meetings, there's a number of new people on the call here, which is fabulous. We'll do some very quick introductions. But the format is pretty informal, as you may see. So we try to keep it conversational as much as we can. And the agenda, which if you're not on our list, you probably might not have gotten the notification. But we sent out there's a newsletter that we sent out and a weekly update. If you put your contact information in the chat, we'll make sure we add you to that. There's actually a review of sort of relevant articles that show up that we want to share with folks. And then we have a couple of topics that we review. We have two updates today that we'll be talking about. And then the main attraction under the big tent is our friends from the Advanced Directive, the HIMSS Interoperability Showcase have graciously agreed to bring the band back together again for a bit. And I want to thank Mary for cajoling, wrangling, and encouraging folks to come to today's meeting and share a little bit more with folks who were not able to see it at HIMSS. I think there's a lot of tremendous relevancy to the work we're trying to do here. And I wanted to make sure that we had a chance to really learn from that great work that's going on. That certainly went on there. So we'll spend the bulk of the time doing that. And so what we'll do is we'll just ask folks who are new to the call just say hello, where you're from, and then we'll go into a couple of updates on our work groups. Brian will talk about the National Science Foundation briefly, and Christine will talk a bit about the use case, the early intervention use case, and then we'll just go right into the presentation, and I'll turn it over to Mary for commentary and choreography, as it were there. So with that, why don't we just start? Robert, you want to just say hello and make serial?
I'm Rob Longley. I live in Connecticut, and I'm a consultant. I've been doing work primarily with Department of Public Health in Connecticut and New Jersey, but I've also done stuff with, I did about 15 years managing the juvenile justice program for Connecticut. I've also done social services in Louisiana, et cetera, et cetera. Okay. And I've been on the NIC for several years and participating in stuff. And I got invited to this kind of by accident. Brian Hansberger did some sort of an update to his profile, and it set an alert off on mine because Google checks for uses of my name, and apparently we had corresponded at some point, and we realized that we're not that far apart. So we started talking, and now here I am.
There you go. Fantastic. Greetings. Right. Welcome.
One of these days we'll get coffee down in Great Barrington.
Yes, definitely.
Thanks, Robert. Robin.
There we go. Good afternoon. My name is Robin Trush. I have been recently introduced to Daniel through an acquaintance in Arizona, which is where I am primarily based. In a previous life, I've been the System Bureau Chief for Children at the Department of Health, which at that time oversaw the Medicaid and Block Grant funding for children's behavioral health in Arizona. I've also worked at an executive level within various managed care companies for kids and families. And then I made the transition to technology about 15 years ago, and now have somewhat of a background in project management, EHR implementation, system redesign, and so forth. And then also HIE. So I helped stand up the original beta site for behavioral health HIE in Arizona, where we were able to exchange 42 CFR data with consent. Then I've also done some consulting work in other states around behavioral health data exchange around consent on the HIE level. So I'm looking forward to the dialogue.
Thank you very much. Welcome. I'm glad we had a great conversation the other day, and hopefully we'll learn more from what's going on in Arizona and some of the work there that's happening. Maria.
All right. Hi, I'm Maria Mullen. I am the Senior VP of Innovation and External Affairs for 80 Volt, and I'm currently the project lead for the HL7 initiative that is creating the interoperable data exchange standards for advanced directive, advanced care plan, portable medical order content to move from system to system.
Great.
Also active on a number of other patient empowerment work groups, but that will at least give you focus as to why I'm here.
Fantastic. That's great. Thank you for joining. It's great. How about Ken?
Okay, let me unmute here. Good afternoon, everyone. Ken Allgood, founder and CEO of HealthFlow.io. We are a patient healthcare management platform. We were the lead on the HEMS demo we'll be running through later from a technical standpoint. And in addition to that, I also consult through DHA and VHA, specifically around interoperability, new system design, and NLP implementation. Have been working with them for about 10 years. I'm also the co-chair for BPM Plus Health on the implementation side. So we're looking for people to join us. If you're interested, once we get through this, please reach out. We'd love to have you be part of the group there. And that's about it, really. Thank you.
Looking forward to hearing more there. Matt, greetings. Nope, you're still muted.
I was trying to space bar and it wasn't working. Sorry about that. So I'm Dr. Matthew Rose. I'm the clinical lead on the presentation that we're going to be giving in a little bit. I wear a number of hats. One is as an entrepreneur, one is as an investor, one is as a Standard Bodies co-chair, and one as a physician. So a few hats there, a lot of different varied experiences in the past, but that kind of gives an idea.
Fantastic, great. And I think the only other new person here is John.
Hi, I'm John from Trisotech. I'm here to support the models at the presentation.
Super. Okay, that sounds great. Anybody else? I think I just have just a 614 area code.
Daniel, how about Oliver?
Hey Daniel, that's me, Rich Boland. So
Oh, hey, Rich.
I was on a couple times before. So, yeah, so
Okay.
had to change the plans and got to drive, so I'm on dial in today.
No problem.
So,
I'm gonna
Yeah.
put your name next to your number there so we don't objectify you in any.
okay, I appreciate that. Thank you.
That's great. Oliver, I think has been Oliver has been on before with us. Oliver Strong, you may want to say hello. It's been a little while, Oliver.
Yeah, it's been a minute. It's good to be back. I am Oliver Strong. I am a senior what is my title anymore? I am basically a product engineer for Interoperability Institute, leading our innovation team here.
Great, thanks so much. Put Rich's name in here. Anybody else new to the game here?
I saw Denis had joined us and then maybe dropped. So Denis is also from Trisotech, very active in the BPM Plus community, an amazing set of tools that we'll see in the demonstration coming up. And if Denis rejoins us, we should give him the opportunity to introduce. Trisotech's been very generous with both their time and their tool offerings and advancing business process modeling for health sector.
Great, looking forward to it, really looking forward to it. So just a little bit of quick updates. For our guests on the call here, you may be familiar, I did send along, hopefully you got some of the materials about the National Interoperability Collaborative and the work we're doing with Project Unify. That is really looking from a pretty open collaboration perspective to bring together national thought leaders and doers to really think about some of the cross-domain interoperability challenges. Been meeting now for a couple of years working on things. The whole idea of the consent service utility came out of that. And Mary and Interoperability Institute and MELD and others, obviously Point of Care Partners and other folks have been sort of walking and working with us as we are developing that concept. And as you probably have seen, and as you probably hear a little bit more, there are a lot of parallels with the advanced directive in terms of trying to improve the data flow and information flow from sort of front to back in order to obtain and manage consent. And as I said, I was struck both by what we've been hearing about, the work you've been doing for a while now, but also the presentation at HIMSS was terrific. So hopefully there'll be a number of places that will be clear for us to be able to sort of learn from one another there. With that though, I want to just take a few minutes. I want to ask Brian, can you, I know you've been meeting a lot with NSF. You got a couple of
Sure, I'll try to keep it brief. I'll try to keep it brief here. The last few years, the National Science Foundation has invested some modestly significant money, 22 to 34 million, I think, a year in open knowledge networks and open knowledge network technology. This year, in preparation for their decision-making over the summer on budgets for the coming fiscal year 2023, they're using a workshop, a monthly workshop process for identifying great ideas from the broader open knowledge network community and working through those ideas to identify the potential for each of, at the moment, we're down to about 18 different project proposals. I think we maxed out at around 36 or 38 some odd projects, pitches in the initial workshop. And we're now working through these 18. Those 18 include, and I should then step back and point out that we, Project Unify, were specifically asked very early in this process by the National Information Exchange Model, PMO, to see if we could come up with some proposals that would leverage NIEM, the National Information Exchange Model, and also leverage our unique capabilities, experience dealing with multi-domain interoperability. So we came out with, I think, 5 proposals, 4 of them specifically from Project Unify into this NSF Open Knowledge Network workshop. One on decarceration, reentry into community and what human services might be needed to support return from prison, jail, etc. One for family reunification, dealing with foster children who get returned to their parents and what their human services, social services requirements might be to enable that to happen. The consent services proposal and a NIEM ontology proposal. All 4 of those have been adopted as in one form or another. The decarceration and reunification projects were merged together during the workshop process. The consent proposal was separated out from decarceration. And the NIEM ontology proposal is moving forward. Eric Jan, if he is on, I don't see him today.
I haven't seen him yet.
You're here?
No, I haven't seen him yet.
Okay. He's been doing a lot of the work along with Tom Carlson from Georgia Tech on the NIEM ontology. They've been making good progress there. I've been leading the consent services and the decarceration project. Within decarceration, within all of these projects, we have a dozen to 24 people who are interested in participating in the process or following the process. So it's we're reviewing this as an extension of the Project Unify working group, making progress on these efforts. We have 2 more months to go through 2 more sessions having to do with ethics and social responsibility, and then the final kumbaya moment where the 18 different projects get together and decide what subset or merger or whatever of all of these projects are we all going to recommend to the National Science Foundation as a proposal for funding for fiscal year 2023. We're not quite there yet. And that's it for me on that topic.
Great. Thanks, Brian. Appreciate that. Christine, would you kind of do a quick update on the use case?
Yes.
One? Great.
So the early intervention use case is our attempt to have, a very specific use case for consent, as well as potentially for other aspects of the work that we're doing. And it centers around a theoretical child who ages 0 to 3, who is in need of evaluation or services through early intervention, which, for those of you who don't know, is a Department of Education program that is available to all children, regardless of how rich or how poor they are. So we're looking then at the consent to move information to connect that child's evaluation in the education sector to the healthcare sector, back to the education sector as the child turns 3, and then connecting to all of the various other supports that child or family may be receiving as well, such as being involved in agriculture programs like WIC or SNAP, housing supports, and other supports as well. So I am working specifically to look at the laws, regulations, policies, and procedures around that at the federal level, and using 3 states with some geographic variability of California, Colorado, and New York. And then we have a group that is didn't meet this week, but next week, hopefully we will start the process similar to what I think is going to be demonstrated today around advanced directives and POST around the journey mapping for this early intervention use case. That's it.
Great. And if that sort of, so locate that in sort of a context, the work that we've been doing and have been focused on lately, and have been making presentations both to Health Data Palooza, to the DASH Network, European Social Network, a variety of places. And the Office of National Coordinator has invited us to help plan a workshop on consent later. I guess it's no longer late spring, probably early summer, but I don't know. We don't have a date yet. Stefan Konya is in charge of that. We've started to do the planning around that. So this work all sort of fits into this larger initiative that ONC is quite interested in. And the idea of a use case, we've been working, and Brian and a bunch of other folks have worked hard the last couple of years to really identify various use cases that we thought might resonate well with the various sites that are interested in actually implementing this program, the proof of concept program. And Christine mentioned New York, Colorado, New Jersey, and also California are interested. So we're trying to find, and we may have found this use case that would be particularly compelling, a lot of tentacles, and that would have applicability in various ways across all of these different implementation sites that we'd be looking at. Robin, you had a question?
Whoop, my hand is up still. My little emoji hand. I'll take it down in a minute. I just wanted to mention to those of you involved in that, and thank you, Christine, as I'm just joining the group for the first time. I am thrilled at the use case scenario in the birth to 3, birth to 5 realm. I've definitely been in the EPSDT side of the house with this population for most of my career. So to hear about going back and forth between education and health, and obviously how the birth to 5 is structured differently in states across the country. I'm just mentioning my interest simply to possibly even talk to you further about what you got going on, and potentially where I can provide some level of assistance to you.
Yeah, that would be great. And for those of you again who are new, a lot of this grew out of the work of the 8 states that were awarded the CMMI Integrated Care for Kids cooperative agreements. And but obviously it's applicable in all states. So Arizona would be one of those. And I know we've got some folks here with Connecticut ties. Connecticut is also an INC state that I'm doing some work with. So, you know, we're hoping to draw them into this process at some point as well too. So in juvenile justice, that's a big piece of it. So I'm curious to hear more there. Not so much in the 0 to 3 space, but as these kids get older, that would be very relevant.
Great. Well, I think unless there's any other sort of new news updates, I think I will turn it over to Mary. And if you want to sort of set it up, orchestrate it, and then hand off as you see appropriate, that'd be great.
Certainly. So thank you, Daniel, and thank you to Project Unify for the opportunity today to bring the people who did the real work. Just let me give a shout out that my piece of this and my direct involvement was very minimal. As my seat from the Interoperability Institute, we're a member of the interop community. We've been working closely as one of the foundational members of Project Unify, but also quickly recognizing that consent is a big space that has, I think Daniel said it best, those tentacles into so many different business processes. So it has been delightful working with the business process modeling for health, BPM Plus community, and alignment with the resources that we're bringing together under an e-consent community of practice, specifically some of the sandbox resources that also support the proof of concept for Project Unify with that health and human services demonstration, and Oliver's team supporting the open source development community for that resource, also working with this team as they pulled together a compelling demonstration around the use case for advanced care directives. I think Pooja summed it up best for the recent Datapalooza in the history and the evolution of electronic consent. And Pooja, you might have to help me here. But consent really began from clinical trials, from pharma industry, and then quickly, oh, consent would be a really good thing for care and treatment, and has evolved over the course of time to now include some of those aspects of consent as consumers responsible for their data. And one big important piece of their data is what their intended wishes are around advanced care directives. I will kick it over to Ed, who's been providing exemplary leadership for the e-consent community of practice. And Ed will introduce the team. And then I just want to give a shout out, particularly to Ken Allgood for his leadership in pulling this team together, but really every member of the team full on contributing the capabilities of their organization, their subject matter expertise. I would be remiss if I didn't call out Amit Trivedi from IHE USA. They curate the interoperability showcase. Unfortunately, Amit was not able to join us today. And also Ben Cushing and the amazing work that Red Hat is doing in not just the space of electronic consent, but really enabling open source technologies, guiding the interop community with some of the best practices, now working with Linux Foundation to stand up an open source program office to support some of the resources that you'll see demonstrated this afternoon. So with that, I will turn it over to the community of practice e-consent lead, Ed Daniels, and then we'll quickly turn it over to Ken and the leadership of the technical team that will be showing us an amazing demonstration today. Ed, over to you.
Thanks, Mary. Matt, I too am experimenting with a space bar here, and I just found out that I have to use my cursor to turn off the mute button. But at any rate, thanks, Mary. And it's nice. Usually, I'm making introductions to hundreds of people who I don't know, and I feel like it's old home week, and I know most of the people on this call, so that's nice and comforting. And in fact, most people that are going to be presenting have introduced themselves in the background. So I just want to frame things up a little bit. A couple of years ago, my colleague Pooja Babra and Michael Solomon at Point of Care Partners did some work for Mary and the Interoperability Institute, looking at advanced care planning and specifically focusing on electronic informed consent and the whole role of consent in that patient journey and workflow. And so we learned a lot in that process, and enough about that process to motivate us all to a year ago, February, present a full day session on the whole use of consent in advanced care planning and in treatment and the other areas of consent. And I think that was a great session. We all learned a lot about the process, and we learned about the breadth and diversity of that space. And moving forward from that, we agreed that we needed to form the e-consent community of practice collaborative, we started out calling it, but later we morphed that into the e-consent community of practice to be able to bring people together to work on consent. And also then we spent time and attention looking at the workflows associated with advanced care planning. And so we brought together a lot of the experts in that area and worked very closely with BPM Plus. Ken mentioned BPM Plus earlier, BPM Plus Health, and we'll talk more about that when we have time or to address any questions. But that group has been instrumental in forming the demo that we're about to present to you today. So the BPM Plus work group, got together to form a demo in anticipation of the most recent HIMSS conference and the interoperability showcase in order to show how the business process workflow processes could work together in a standards compliant manner to bring together multiple vendors in order to manage the workflow process, in this case for advanced care planning. And so that's what we'll be talking with you today about. The people that'll be presenting, I think, Ken, you'll probably introduce them individually, and they've already introduced themselves, but I also want to make sure that we, as Mary did, acknowledge the role of Trisotech and Dr. Johns Verbley, who will be sort of behind the controls here for that workflow visualization system. And also, of course, Maria Moen, who spends her life on advanced care planning and helping people understand how that can work in a multiplicity of different types of environments, that all requiring interoperability and facing all kinds of interesting interoperability challenges that she can talk about. So without further ado, I'm going to hand it over to you, Ken, and I'll stand by to address any questions anybody might have for me. Thank you.
Okay, thanks, Ed. So let me go ahead and bring these up real quick.
I give you control there, Ken.
Okay.
Did I?
Let's find out.
While you're doing that, I just wanted to say that, and I put a resource in the chat here, I think I did, that builds off of the what Ed was just saying about the work on advanced directives. When we did a environmental scan of promising practices, we really built a lot of that on the work of Point of Care Partners and the work on the advanced directive. So there's a long linkage here with the work. So just wanted to share that with you guys.
Okay, excellent. And I appreciate that. Can everybody see the slide?
Yep, we got it.
Okay, awesome. Excellent. It's wonderful when things work as expected. So thank you all for the time today. As Mary mentioned, and as Ed so eloquently introduced, yes, this was absolutely a group effort. As highlighted here on the center slide, 80 Vault, Cerner, HealthFlow, Red Hat, TriSutech, we all came together under the auspices of BPM Plus Health. Where Ben Cushing from Red Hat and I lead the implementation working group. We started this off looking for some potential use cases and targets that we could really represent what this interoperability, what standards-based interoperability can do, and came up with advanced directives as well as the human trafficking workflow that we put together for, we were sitting side by side for those that found us at the most recent HEMS. So without further ado, I'm going to go ahead and roll this forward. We'll have Matt Rose go ahead and walk through the clinical use case as we roll forward and introduce our lead here and his life and his daughter and how they've leveraged AD to make sure he gets the care he needs. Go ahead, Matt.
Perfect. Thanks, Ken. And welcome to Advanced Directives, the Patient's Voice. We're very excited to have you all here today. Before we get kicked off, I have a couple questions for you. And if you can, just take the chat. And if you just open up the chat box, I'm just going to ask a few quick questions. First, how many of you actually have an advanced directive? If you have one, just put Y or yes. If you don't, say no. Let's just see how many people, just take sort of a quick poll here. All right, so I'm seeing a lot of yeses, a lot of nos, pretty much really in this group, I'm seeing about a 50-50 mix. So if we actually look at the US population, about 33% of the US population will have an advanced directive. So it's great to see that there's greater than that amount here just on a scan right now. Second question is, how many of you actually have a parent that you know has an advanced directive? And then there's a second caveat to the question is that you know where to access that advanced directive. That's brilliant. I love it. I see yes and have access, a few yeses, and that's brilliant. I love it. All right. All right. Fair enough. And so with that being said, the last question is, how many of you actually think that if any of us were to end up in the emergency department today, they would actually have that advanced directive information if we did have it? So I'm seeing a lot of no's. I saw a couple of yeses from people who are part of the speaking team here. So that's great. All right, great. So, I mean, if you think about that, it's pretty impactful. If we think about the past 2 years with COVID, how many people actually ended up in the emergency room, unable to communicate for themselves and unable to have family present with them, right? And how many of them maybe had an advanced directive or didn't to actually communicate their wishes? Even if they did, probably wouldn't be accessible. So this is the point of this vignette, is really to focus in on that sort of use case of COVID-19 and really looking at how do we address this issue? And we may actually have treated patients in ways that they didn't want to be treated over the past 2 years. And, potentially that's against their potentially patient harm, right? Because we're treating them against their wishes. And so really, how do we address that and how do we reduce that? And that's a big part of creating this interoperable flow. As Ken had mentioned here, through BPM Plus Health, we were able to organize a great team of 6 organizations: Red Hat, HealthFlow, Cerner, Interoperability Institute, TriSutech, and 80 Vault, to all come together and work together over a 1.5 month long period to bring a technology solution forward that created interoperable flow to deliver an advanced directive within minutes of a patient arriving in the emergency room. So next slide, please. So as you can see here, we brought together about a little over a year ago, we brought together a group of multi-stakeholders, really through BPM Plus Health, to create a flow and really create a standard around what happens in the emergency room with advanced directives from different perspectives. One was a nursing evaluation, which you see here on the screen on the top right, The other was a licensed clinical provider perspective on the bottom right. And really this multi-stakeholder group consisted of administrators from different health systems, providers, nurses, technologists, and vendors, as well as standard body organizations. So really to come together and create what would be considered a best practice flow of interactions or business process, right, within a specific system. So next slide, please. So I'm going to hand over to my colleague Ken, who's going to take over and introduce the business process modeling and explain a little bit more about BPM Plus Health and take you through the rest.
Thanks, Matt. So as we've mentioned before, BPM Plus Health is a standards development group. I don't know if they can call us that. We live under OMG, and our intent is to provide reference standards for best practices to really drive forward adoption, to move past that 9-year adoption cycle, which currently is kind of the standard, unfortunately, within health organizations, and really enable a learning health environment. And so from that perspective, we're leveraging BPMN, which is a standard been around for a long time. I myself have implemented it in support of supply chain at DoD and for corporate partners. We've used it in a variety of situations. In this case, we're taking that well-proven standard, which can enable automation on the back end and really support the actual human activity, because health is not data. Health is an activity. Healthcare, rather, is not data. Healthcare is an activity. And so our goal under the auspices of BPM Plus is to leverage that graphical notation around business processes, really identify what the human interactions look like, what the system interactions look like, winnow that down to what really are the best practices, and then capture that in a way that's understandable by business users, but again, can be automated. And as we'll walk through, or as John will walk through shortly within the TriSotech platform, that we used not only to help drive these activities behind this demo, but also as a walkthrough of exactly what was happening. It's code. This isn't just a drawing on a whiteboard. This is executable code that can support the actual delivery of care. And let me unmute myself again. So this is a representative architecture, what we put together. To Matt's point, we did this in about a month and a half. I would have rather had 3 months, but things are what they are. So we found ourselves, after working together under the auspices of BPMN Plus, we discovered that HIMSS had given us Cerner as an EHR partner. And so we incorporated them quickly into the workflow. All of the pieces on the back end, as far as within the pink box, everything is standards compliant. And what we were able to do in working with Cerner is leverage FHIR in a couple of different facets to be able to push AD Vault stored documentation, as well as the patient's actual healthcare information for the past few cycles, as well as information that they have been gathering themselves while they're at home, and be able to push that to the ED department whenever, as we'll see, they had no previous record for Emmanuel. And so by leveraging this automation layer and that BPMN flow that we just took a look at, we were able to, number one, ensure that we had the right documentation, that consent was given and managed from the beginning to the end of the flow, and that the ED department had what they needed to treat the patient as they wish to be treated. On the left-hand side, again, this is all within the Red Hat OpenShift container platform. We had HealthFlow providing interaction via mobile devices that's with the patient themselves, and it can be the clinical team. In this case, we use Cerner for the clinical interactions. We wrote everything from the MELD environment, which served as a back-end EHR, so a historic EHR on the part of the representative patient's provider, as well as the documentation that we received from AD Vault when we queried them. We brought all that together, leveraging the various Red Hat integrations. And again, behind all of that is the TriSotech engine that's helping to automate that, bring the different pieces together, and then ensure that the right pieces are happening at the right time. Any questions? feel like I'm going quickly. So, okay, all right.
But actually,
we'll roll for it.
if you do have a second, maybe just go back one slide, Daniel.
Yes.
Can you just say a few more words about TriSotech and the ability to integrate all that stuff? That seems like a critical piece.
Well, certainly. So, and John, you can provide additional detail, and I don't know if Denise has rejoined. But in this particular case, we leveraged TriSotech as the automation engine running the BPMN process. So we had basically leveraged it from the perspective of bringing all the different pieces together and orchestrating the flow of the information. So taking the notification that we're receiving from Cerner and actually pushing that then to the provider notification, pushing that provider notification out to support the health flow receipt of that, and that initiates the entire flow. And John's going to walk through that shortly. But what it did and what we used it for in this particular case is really providing that orchestration layer as well as rules that everybody else lived by. And in addition, health flow, we're using BPMN within our platform as well. So we have our own automation layers that integrated with TriSotech and basically used it as the directional component. It provided that trusted foundation to really guide the remaining components within the orchestration of the delivery. Does that answer your question?
I think so.
Okay, cool. And again, we're going to dig into it in just a moment as we walk through step by step and show really where TriSotech is helping to direct and bring this information together. I'm going to pass it over to Matt now.
And I think there's one other comment on this picture. As we work with BPM Plus, and also, as you all know, couched within the health information exchanges, working with Civitas in the work that they're doing to define health data utilities, very excited about this architecture, the containerization, the reuse of the workflow and decision automation engines by TriSotech, being able to enable on the MELD sandbox. AD Vault has that expertise in advanced care plans, could just as easily be a case report, behavioral health case report from a social worker. And so the power that I see in the BPM Plus and these architectures and bringing these solutions together is that reuse as we look at defining and packaging the modularity of the different components that make up a health data utility. So this particular diagram really spoke to me and some of the work that I've seen Civitas doing around HDUs.
Thank you, Mary. And that really does highlight, again, why we use within HealthFlow, the BPMN, is to allow for that standardization. And as new requirements come out, you can apply it literally across the board globally. You can apply regionalization, you can apply a variety of other things and still leverage that shared process from end to end to ensure the best practices really make their way to the field.
And so Ken, just along those same lines, do you, just for point of clarification, when they use BPMN modeling like this or these standard models, does everybody have to use the same software on the back end, or can they use different software
not.
systems?
No, that truly is the benefit, and again, why we are focusing within the BPMN Plus implementation working group specifically to build a library of reference implementations with processes that you could take and put in your organization, where obviously Mayo is part of that. We have IOI, we have a variety of different groups and that are engaged in this, and we're always looking for other implementation opportunities. We actually have an upcoming pilot with DoD out at Madigan in the Seattle area, specifically around presentation of not only incorporation of AD, but also presentation of that within the context of an overarching workflow, because Cerner simply can't do that. So yeah, that's the other benefit of this. To your point, yes, I can take the standard process and drop it into any standards compliant workflow engine, but more importantly, I can now run that outside of your EHR EMR. You don't have to try and implement this within. And so again, implementation, adoption, and really, standardization across the healthcare delivery spectrum is really being driven forward here. Any other questions? All right, Matt, it's on to you.
Perfect. Thank you. I'm actually going to hand it over to Maria, who's going to introduce Emmanuel at this point.
Well, thank you. So let me introduce you to Emmanuel. He is a proud gentleman who doesn't want to burden his children with his health issues. He is 76 years old and he has enjoyed a relatively healthy life. Recently, he moved from Ohio to be closer to his daughter, Katrina, and he now resides in an independent living community in Michigan, close to his daughter. That particular senior community in Michigan has a wellness center at the hub, and that wellness center is staffed with clinical professionals that serve that entire community. So go ahead, next slide. Thank you. So Emmanuel's community-based physician invites him to complete an advanced directive, advanced care plan prior to his annual wellness visit using his My Directives for Clinicians. And you can see an example of the email. So, hey, Emmanuel, Martha Middleton from the Wellness Center is requesting that you create or update your advanced care plan, and then Emmanuel is able to engage with that particular process. Next slide. So Emmanuel and Katrina both work together to complete his advanced directive. Oops, go back one. Advanced care plan at home using the consumer-facing My Directives platform. So for all of you on the phone who are, looking at services, My Directives is free to consumers. So when you're working with some of the communities that you're working with, please encourage them to go to mydirectives.com. It's a free platform that is highly interoperable on the back end. So using My Directives in response to that email, Emmanuel designates Katrina to be his healthcare agent, his medical power of attorney. And he also separately grants access to his information to Katrina so that they can review and discuss his documents together. Go ahead, next slide. And this is just an idea of, how simple it can be for consumers to engage in their own health and wellness. So very simple UI, and what you click turns green, and there's a whole lot of free text fields. But you'll notice here, Emmanuel has said, there's a lot of things that are important to me, but I don't want to have a ventilator if I get COVID. So remember that point. It tends to be a very key point as we move forward in this journey. Next slide, please. So you will see here that there is outreach provided. On the upper left-hand side, you can see where Katrina is invited and asked to serve as his healthcare agent, utilizing some rather technical terms in the world of fire. This utilizes an element called the consent resource. So he is consenting for Katrina to make treatment and healthcare decisions for him in the event he is unable to make those himself. On a separate issue, he can also give access, so there's consent to access that is provided by Emmanuel to Katrina. And you might be asked, well, why are you separating these? Because logically, he may want to designate Katrina and know that she's willing to serve in that capacity. That's a very weighty role. And he may want to talk to her as he did. Let's talk about what's important to me. Let's talk about what's in here. Now that we've had a conversation or multiple conversations, now I can grant you access. So those two threads should be separated. Next slide, please. And then when he goes in for his annual wellness visit with the practitioner who said, we really think it'd be a good idea if you did this, he is able to discuss those decisions, the risks and benefits of the treatments that he has indicated, and the primary care physician can get on in there and really work with Emmanuel to engage him. Now, what is important to note that when these discussions occur, when these services occur in conjunction with an annual wellness visit, it is all 100% covered by Medicare with no copay, as long as you have a special modifier code on that claim that indicates that two services were provided And so both of them can be paid to the provider entity with no, back office administration and trying to collect that copay. So go ahead and go to the next page, please. And then you can see here what the physician is able to see. Hey, Emmanuel, I see that you did this. I see your documents. I see that you uploaded a state advance directive. You did a personal advance care plan, and I can access this and I can dialogue with you on these elements. Go ahead, next slide, please. And you can see how the physician can actually pull up the actual scan documents. And Emmanuel's very clear. I do not want any prolonged dependence on machines, and I don't want a ventilator to breathe. And I don't want, my daughter or others to have a financial impact. So these wishes can really help to inform treatment. Next slide, please. And then again, you can just see the various documents that the physician, the practitioner has at his fingertips to have that risk and benefits conversation. That physician and practitioner involvement is really key to making sure that there's harmonization between multiple types of documents, which unfortunately in the US healthcare system can actually be a point of fact. You can record all of your wishes on an advanced care plan. You may need state or jurisdictionally based advance directives. And depending on the care setting or what needs to happen in your status of wellness, you may also need a portable medical order of some type. So we do find multiple documents being executed and stored for individuals. And I think one more slide. Great. So Matt, I think I'm going to toss the ball back to you.
Brilliant. Thank you so much, Maria. Just one point about the primary care physician's discussion here and why it's so critical during these annual visits to have that actual consultation, and really brings to light here some things that it's near and dear to my heart and personal because I've experienced it with my father, is that, Emmanuel says he doesn't want to be on a ventilator, right? Because in Emmanuel's mindset, a ventilator means intubation. But in medicine, there's a big distinction between being on a ventilator and being intubated, right? Because you can be on a ventilator and with a face mask, or you can be on a ventilator while being intubated. So by meeting with the clinical staff and the clinical team, the primary care provider, they can actually work through that, have that discussion. Well, what did you mean by a ventilator? And make that distinction so that Emmanuel's wishes are actually met, and then update the document right there within my directives so that they can have a clear, distinct version and the most up-to-date version that actually matches that patient's best wishes. That one who is maybe outside in the traditional community, it maybe doesn't understand what happens behind the scenes in the hospital. So with that being said, we're fast forwarding several months. Emmanuel starts to get sick. He's doing okay, but he gets a fever. He starts to develop a cough and a loss of taste. And these are the signs he's been watching on the news, right? He says, I got to go to the wellness center, a doctor, to get tested. He gets tested for COVID-19, and unfortunately he comes back positive, but he's a mild case. So they send him home. And they say they send him home, and we'll go to the next slide, please. They send him home because he's a mild case for isolation. They give him instructions on isolating himself, as well as they say they're going to send him a home care kit that will include a blood pressure cuff, a pulse oximeter, a thermometer, and it's all going to be connected to the Health Flow app that will be on a telephone that they'll help him install. So that once all that comes connected, ultimately the health team and the clinical team will get all those readings simultaneously, but then they're also going to give him a daily telephone call just for a patient assessment questionnaire, just to see how he's doing. So it takes about 3 days for the home care kit to get there. Unfortunately, it took a bit of time with delays and transit and everything else that happened during COVID-19. But it got there, and at day 3, he's relatively the same. No significant changes. Mild fever, cough, and loss of taste still. Just a little bit more fatigued. Day 5 and 6 occur, and his fever worsens, and he starts to develop chest pain. Obviously, he's coughing a lot. He's not thinking much of it. But remember, he doesn't want to worry his daughter. He doesn't live with his daughter. She's about a half an hour away. But yet he's still having daily video conference calls with her, and because she's obviously concerned, wanted to make sure he's okay. So he puts on a strong face for her throughout this entire time, and really pretending like nothing's absolutely wrong other than maybe the cough. Day 7, he suddenly has a significant decline. He can't get out of bed in the morning. And he really is having trouble breathing. So he says, look, I just, this is not good. I actually need help. I'm going to call my daughter. So he calls Katrina and tells her he's having a lot of trouble. He can't even get out of bed. He's really having trouble breathing. Katrina says, Dad, we have to call 911. So Katrina calls 911 and gets emergency services on the line. Next slide, please. So EMS arrives at the scene. They recognize that this is a critical case. They place oxygen with a non-rebreather mask on him, and they call ahead to the hospital as they escort him into the emergency vehicle. They say, we're transporting a 76-year-old male with COVID-19 that is unstable and rapidly declining. He has a GCS score of 12, oxygen saturation rate of 73% on a non-rebreather, a heart rate of 120, and a respiratory rate of 36. He's not doing well and he's declining. Katrina is notified that they're on the way, and so they are transported on as they're transporting him to the hospital. The hospital staff in pre-registration takes their Cerner system and starts entering his information into the system. They see that there's no information at that local hospital for him. Remember, he just moved from Ohio to Michigan. So there's nothing in the HIE for him, and there's nothing actually in the system about him whatsoever. So he literally, it's a blank chart. So this is where we start off to trigger the events. And so let's take a step here and pause and think about what happens in the case without the automation that we're about to propose. So and this happened over the past 2 years many times. The patient would arrive in the emergency room. If there was no advanced directive or advanced care plan available for them to review, they would have to hold a consultation with the patient or the family member if they were stable and if they were able to communicate, right? They would have to document that on the appropriate hospital form. They'd upload those documents into the system, or they'd have to wait for a family to provide existing documents. Okay. And if the patient's not able to communicate for themselves, they have to search as quickly as they can for all this information using the staff that's available and resources that are available at the emergency room. And if none of that's available, they're going to treat him with the best standard of care. So think about the time, the cost, and the labor that takes in the emergency room to do all of those. Ultimately, in most cases, to end up treating a patient against their wishes, because usually that information is not available if they're unstable and unable to communicate. With this interoperable automation solution that we're about to go through, it identifies that Emmanuel is a new patient and a request is sent. The family approves that the information be shared, and then the data is in the hospital records within 30 seconds of the patient arriving. So I'm going to pass it back to Ken to take us to the next step, and I think perfect. Oh, sorry, John. I think this is John's.
Well, no, it's okay. It's all right. So what we're going to do now is we're going to run through the actual automation within TriSoTech. And as Matt highlighted, whenever they initially started putting in his name, it kicked off, it's a blank record. They didn't have anything available via the HIE. That kicked off a notification from Cerner to a subscriber base. Providers can subscribe to it, letting them know that this patient is in the hospital. That kicks off this entire process that John's going to run through right now. And John, are you ready?
You bet.
All right.
Well, showing on the screen is example of a process model from TriSoTech, and each of the horizontal zones that are colored represents the work done by a specific member of the healthcare team. So at the top we have Cerner, the middle orange area we have health flow, and then the lower level we have 80 volt and remote EHRs for checking remote data. This is event driven, and the events that occur that are going to be the primary drivers are all messages. And a lot of the work is coordinating the sequence of events and then the message flows and tasks that get performed. One aspect of the model is that it's contained by time. In many other real life situations, the process might go over days or weeks. For this, if they are unable to retrieve a adequate advanced care package within 10 or 15 minutes, they will go, as Matt said, to the best level of care. So it starts at the top left, where the patient is in transit to the ER, notified by the squad, and then it goes to a square, and that's a task. And the first task is to look locally for information to see if there's any information present. So this triggers a call to HealthFlow, and then HealthFlow coordinates the calls to 80 Vault and the remote EHR storage. And basically, we have an animation here that shows the process. In practice, this would all be programmed, but this is here so you visually can see the various steps. So
yeah,
ready for
and
you.
the only thing I would add is this right here, even though it says request for patient data, it's that notification we spoke to earlier. That's really what is being sent out by Cerner. It's labeled this way because that realistically within the workflow, this made it a lot easier for everybody to know exactly what was happening. But we are, in this particular use case, HealthFlow was listening on behalf of the healthcare provider for these messages, and then that's what kicks off the entire process on our side. So here we go, John.
Okay, and basically this is animation. It shows each step as it goes through, and internally, they'll be all done electronically. And so requests go to 80 Vault and then to other data repositories to search their data. When they find something, it comes back. And as it comes back, then it goes to a task to consolidate the information, see if what consent is given, and then it's pushed back to Cerner, which then makes it available to the clinician.
Exactly. Thanks, John. And now treatment can begin. And now we'll walk through the actual applications where this is happening, what's driving it. Hopefully we'll walk through. Let's go to the next, see if it works this time. No. There we go. Cool. So this is a notification from Cerner that goes out. This is the one that we pick up, and that kicks off this entire process. This is a secure email that Cerner sends out to subscribing providers. It provides information regarding the patient's name and also some identifying information, why they're being admitted, the particular date, the message date, as well as some additional ICD-10 information, and most importantly, the facility itself. So we have a facility identifier, so now we have a target that we can work towards. As Matt said, part of the provider's offering for their patients is the HealthFlow platform. We have a clinical side that helps coordinate care, as well as a patient empowerment side. That app allows for you as a patient to actually select your personal healthcare team and gives them consent to view your records. In this particular case, as Matt said, he called his daughter. So she is aware that this message is coming. She knows she needs to push the information forward. She gets this notification that, hey, here's the information that's being requested. It shows up in her HealthFlow app. This is what we've received on that step within the process flow where we've brought this stuff together. We've aggregated this information, we've filtered it, and we've aligned it with the constraints that were previously defined by the healthcare provider for this share. As you can see, she sees the DNR. She also sees the additional advanced directive information here, the in case of emergency, my wishes. And we also are able to provide the patient-provided health information. This is the information that Emmanuel has been capturing, and this is a subset of it, that he's been capturing while he's been sitting at home hoping to get better. So we aggregate all that data and present it to her in a quick view, allowing her to review it. She can actually drill down into each one of these if she wants to get a better, just dig into it and see what's included within the package. She selects consent and presses share. What she receives back once that information has been pushed, that it has been successfully shared, the recipient is Michigan General, been sent along with the permissions and the access to download the selected documents. You'll be notified when the documents have been accessed. Additionally, the share access is active for a set amount of time. So the actual patient or their family can select that, obviously with the provider's guidance, to make that documentation continuously available for a set amount of time. That also gives the treating physician, in this case the ER, the capability to request additional information about a manual if they need more of this history. If a manual had arrived at the hospital and he was conscious, he was able to share and speak to them, he could also have simply had them scan the QR code and provided that same information himself. On the Cerner side, once that whole process has been run through, once that consent has been given, we shift from a blank file into what they actually see on their side now. You can see here, they've got and it showed up in a critical note format. It was interesting working with Cerner to get everything to show up inside of their environment. But we did it. And so it shows up as critical notes for the ER department to actually be able to go in. Hey, you've got this power of attorney. We've got summary notes as well. And we also have, in addition, this is where the data that was pushed over, the COVID-19 identification, as well as some cardio information. Within Cerner, when they received this document, we were able to push it over as a document ref. They cannot receive FHIR packages as yet. It's something that's in process. So we were able to push this over as a document ref. They were able to bring it into Cerner. And you can see here, they could actually bring up the written document, the signed document within the ED view. Again, over here, we've got the heart rate, we've got the temp. These are all the elements that he had previously collected. And here's all the clinical documents that made their way over. This is a full set of the documents that were pushed over, the continuity of care document, as well as the full set of advanced directed documents that are available. They can drill down into each one of these. These were part of the package that were sent over. Again, we pulled this directly from AD Vault in FHIR. We packaged it together along with the health data and made it available to Cerner within that same context once consent was given. The immunizations that he had already received, this is part of the package that we pushed over as far as his previous health data. We can see he has influenza, pneumococcal, as well as he has been vaccinated for COVID. Unfortunately, he still, as often happens nowadays, he still came down with COVID. Also have some past history here of the medications that he is currently taking, so that the ED department has a much better picture of, basically his most recent history, as well as things that might be in his bloodstream. Matt?
Perfect. Thanks, Ken. So
You're welcome.
I just want to pause here before I continue with the story and just answer a question that was posed. And that is, does the ED need to adopt the solution to make this a possibility? And there's a couple of points here that the answer to that question is really two answers. One is part of the reason why we collaborated for this interoperable solution is to connect the unconnected systems that aren't currently connected to the hospital, right? So what Ken showed you there was collecting vital signs, collecting other data in terms of medication, collecting histories, and other capturing other information that's within the GP office or in other locations that HealthFlow is packaging and bringing forward to that ED. So in that particular situation, in that one scenario, if you want all of that information, the ED has to sign up for the services and be and subscribe to them, right? In a scenario where all they want is just access to an advanced directive, and the only repository that we're concerned about is the AD Vault repository, that is already a functional system that's already integrated, where AD Vault has created an integration into through the Commonwealth Health Alliance and a number of other areas. And Maria can speak more to that later on, so that the document is available in EDs today. So there's really two scenarios here, which I want to bring to light to answer that one question. And it's really depending on how much information you're looking for, what you need to provide the best clinical practice of care.
And if I may, Matt,
Yeah.
the ED does not actually need to be a partner or a client of HealthFlow. We can push information to them. It's, in this particular case, it can either be the patient alone or the patient's provider.
There you go. So apologies, I misspoke there. Sorry about that, Ken. Yeah.
No
Thank
worries.
you for the clarification. So with that being said, though, shifting focus now back to Emmanuel and his story. The brilliant thing here, what you saw, was that now the ED has Emmanuel's information. They have, for the past 7 days, the patient reported outcomes, right? The telephone calls from the first 2 days. They have all of the IoT connected device information, his saturation rate, his temperatures, the progression that's happened there. So as a provider, I can look at that chart and understand what has been going on with him over time, but also to help me understand where potentially he's headed, knowing what I've seen in the past, but then also looking at his advanced directive of what he wants to happen in the event that he is here under our care. So knowing that he did not want the ventilation, but he actually had a discussion with his GP, or his primary care provider, I should say, that clarified that he didn't want to be intubated. It wasn't ventilation, he just didn't want intubation. I can now make a determination that the image on the right is not going to happen. I know he's in a severe critical condition. He needs to be supported with some sort of ventilation, but now I can actually put him on a full face mask and actually have support ventilation using a full face mask rather than intubation. Even though it's not potentially as effective as a treatment, it will significantly support him in terms of what he needs to help raise his saturation rate. So we end up doing that in the ED, and so we prepare him, we set him up, and we then engage with the ICU and begin the transfer paperwork within the system to transfer him over. 30 minutes later, his daughter arrives in the ED to catch, as you know, she called in to emergency services, and she got there finally because it took about 30 minutes to get there. And when she arrived, the nurse explained what had happened. And to Katrina's happiness, she was very relieved to learn that he wasn't intubated, because she had heard so many stories of patients coming in severe cases being intubated, and she knew from her discussions with her father that he didn't want that to happen. So she ended up going to her father's room to be there and support him based on the hospital protocol with COVID, and was able to support his transfer to the ICU. He was in the ICU for several weeks. And as you know, it's a dicey situation, but many cases didn't come out of ICU. In Emmanuel's case, he did. He was one of those survivors, and he was, as you know, what wasn't mentioned before is that he was part of a choir prior to COVID. Singing his deep voice and songs. And so fortunately, after weeks of recovery and dealing with some of the after symptoms of actually having COVID, he was able to return to his choir and be a part of the community again in his age. So
don't forget the salsa dancing that has to come into play.
Definitely, we can't forget that salsa dancing, that after evening activities, the salsa dancing and singing. So
we had fun doing this demonstration on the floor of hymns.
And so with that being said, the amazing thing of what you saw here was a collaboration of 6 different companies who normally don't have a relationship, right? Who potentially may have competing interests, but they all came together with one focus, and that's really to drive a better quality of patient care under leveraging a standard that had been created through best practice and discussions across multiple stakeholders in the industry. It ended up saving the ED a lot of significant resources and time and money. provided the right information at the right time. And it was a platform that's able to scale and integrate the multiple vendors and products with a great solution. So open to any questions and hand it back to Ken and the rest of the team.
Thanks, Matt. Thanks, Matt. Thank you very much for wrapping that up. I think that really, again, what we're looking to do with BPM Plus is create these reference implementations that I can take this and drop it anywhere. And it use the standards to integrate with AD Vault, use the standards to integrate with the variety of health data providers that are coming under the auspices of Civitas and other HIEs. So we can leverage this in a reliable fashion to deliver better care across the US and the world. So happy to answer any questions about the implementation itself, about BPM Plus, and obviously Maria can go deeply in depth into advanced directives because she was in just an encyclopedic knowledge of all of this stuff that we don't do. So I'm like, really? It's different between Ohio and Michigan? You got a handwritten here, but not here? It's crazy.
Yeah, the project has been a real education on the jurisdictional variances that exist not only within a single state. So you might know that there's a Maryland Advanced Directive and that Maryland subscribes to the MOLST form. Did you also know that there's a Catholic Maryland Advanced Directive and there are just variations upon variations? When we created the standards, the FHIR-based API standards, we had to perform a full environmental scan and make sure that we provided an on-ramp for any jurisdiction that wanted to implement FHIR-based exchange. And one of the screens that Ken showed, we were heavily informed by our clinical population. One of the screens that Ken showed, we actually deconstructed all of the available data into discrete categories based on the beseeching of the clinical community. There is a section about the healthcare agent. There is a section about your upon death preferences. There is a section about your end of life treatment preferences. There is a section on your care experience preferences. And so just a lot of work was done to really break the bonds of paper and using the ONC's preferred mechanism for delivering secure health information, which is FHIR. We were really able to take these documents that we know and liberate them into useful, usable, clinically relevant pieces of information. So
That'd make a great graphic for the ONC consent conference.
Yes, yeah, absolutely. We'd love to help. And the ONC is watching. CMS and the ONC both fund aspects of the project that I lead. So we definitely have their full attention.
Absolutely. Well, I want to thank the whole team. Thank you for taking the time this afternoon to share. I just want to highlight Ken's summary. Really, the community of practice is about bringing together the standards. We're super excited of what this BPM Plus standards bring, particularly the synergy with all the good work that's happening with 7 and with FHIR. Now some of the NEAM activities that are coming to the table again with Project Unify, just able really with an implementation focused, working with IHE and HIMSS, working with Civitas, working with ONC, their upcoming electronic consent workshop, just contributing the resources to be able to stand up these reference implementations and show the power of bringing solutions from the standards organizations, from private sector, some of the policy drivers that we see coming in from public sector. So for the Project Unify community, if any or all of that is interesting, I put a link in the community. We've been holding a little bit on really doing a convening of the community of practice, since if you did the Venn diagram, there's a strong overlay with participants in Project Unify. So we've been talking to Daniel about how we can most efficiently use people's time, do venues like this so we can targeting some of these industry venues that bring in a wider group of participants to look at how are we packaging up these health data utilities? What are the standards that underlie them? What solutions are already available in the marketplace? And how do we really enable moving all these tentacles of electronic consent forward? So thank you again to the team for your time this afternoon, for bringing this demonstration back for the Project Unify participants. And thank you to Daniel for allowing the time for us to share this important work.
Thanks so much, everyone, for this. I'm it's even better the second time. It actually works well on the screen. It's a good demonstration. I know that I continue to see some of the applications as we're thinking about related areas, and you heard a little bit of that up front relative to the kinds of consent we're trying to capture and manage or think about managing relative not only healthcare consents but education, behavioral health, other things like that. So
the nice thing about these workflow tools is they're not really narrowly specific to healthcare. They can be applied to all of these different disciplines or sectors.
Absolutely. Sorry, go ahead.
Oh, I just want to highlight, Ken, a comment that you made earlier. I was astonished last BPM Plus meeting, and I'm rarely astonished these days. I didn't realize that the BPM Plus standards, as you run it through the tools, you actually build a computable object, and that computable object can be embedded in any piece of software. The piece that astonished me is you don't have to go back to the development team to build the software code every time. This componentization, the modules that we've been talking about for being able to enable these health data utilities, they're happening today. And the people resources, it's not that you need an army of software developers to be able to enable these solutions. Power of what those BPM Plus standards resulting computable objects provide.
Now, Robin, did you have your hand raised?
Yeah, I just wanted to make a comment to the comment I just heard.
She's so polite.
The applicability of this. One of the swim lanes that I'm in right now and have been is behavioral health crisis services, and in particular, working with people that have a serious mental illness. Advanced directives has been and will continue to be a super hot topic for that population. But beyond the advanced directives piece of what was just demonstrated, what I think about is with the implementation of 988 around the country and the impetus to really expand crisis services, where does this fit? So I'm hopeful and excited for some ongoing discussion about moving towards addressing some of those care gaps with tools like we just saw.
And I can tell you, excuse me, Robin, we're doing some work with Chris DC right now, and they are having us implement the mental health directive in that particular area because they're looking at very targeted outreach to behavioral health recipients, and again, trying to work with these tools. So there's a huge rise of interest in going beyond advanced directives to maternal birth plans, mental health directives, anything that a person needs to have memorialized that impacts the care and the treatment they receive. That's where we have to keep moving.
And I'm sorry,
box.
There was a gap when you first started talking. Who did you say you're working with right at the beginning? You said Chris?
Chris DC. So,
oh, Chris.
Yeah, Chris.
Okay, sorry.
The HIE. So the HIE in Maryland also has a chapter in DC. You bet.
Yes, thank you.
Yeah, and I was simply going to offer that that flexibility and deployment across a variety of different environments can really drive standardization. We're doing a deployment right now under NAC It's a CDC funded deployment, but across 14 individual health centers to be able to standardize care delivery and start to standardize also patient outreach, to really accelerate that and really empower the people in the field without them having to log into an EMR or EHR. This is being done underneath the auspices of the COVID grant, but we're using it, they want to use it to actually really standardize health delivery across the health centers themselves, and also use it as a point of health information exchange. So the possibilities are truly endless, and it enables us, again, to the earlier point, to really accelerate that adoption of best practices. And as regulations come in, as even regional changes come in, those rules can be referenced outside of the business process itself. So we're able to customize it and use, to Ed's point, a single consent business process that can be used for a variety of situations. It's all dependent on what's coming into the process that then says, well, call this, look for this, and do it this way. But you have that same consent process that makes sure you have all of the right pieces coming together to really protect and deliver better care.
Yeah, to add to that, Interoperability Institute, we're working with some of the clinical associations who have taken the BPM Plus standard in their clinical practice guidelines, put it into the standard syntax, and are now needing a sandbox to be able to stand up reference implementations of those clinical practice guidelines. More recently, the NIH funded activity on medical computable knowledge objects, MCBK. I can never remember what MCBK stands for, but bringing some of the work on the knowledge grid that's bringing in some of the genetic components, some of the personalized medicine components, to be able to have those computable objects that you could embed into software that just gives you a further breadth and depth about an individual situation and that interaction between that individual and their care provider and their family and other stakeholders in their care.
Ken, I wanted to just ask you a question about that, the business process and having the rules outside of that, basically, if you're still there. That one of the things we've been thinking about, or others kind of still connected here. But one of the things we're looking at is obviously every state has different privacy laws, and even though they shouldn't, some of the counties in the states have their own variations on a theme, despite the particular state laws. Our attorney is not. Oh, Chris is still on the phone here. Great. One of the questions is, dealing with not only HIPAA, but FERPA and 42 CFR and DB and other ones like that. They'll have a unique set of, legal constraints and requirements by state. Business processes are different in terms of, acquiring those consents and making sure that they're understood, and then aggregating those in some way. And maybe this is probably for another conversation, but I just wanted to get your clarification that those different rules you're saying can sit outside of it, the basic engine, so to speak. So you're not having to reconfigure the whole machine, basically.
No, that's correct. So we use DMN, which we can. I think this deserves a deeper conversation. Okay. But yes, so the rules that actually are used to then guide the processes, as well as any reference sub-processes that might be called, to your point, based upon regionalization, state alignment, whatever it may be, all of those pieces can be outside of the best practice process itself. So yes, it allows for a level of flexibility that I think I mentioned earlier as global rules come in, whether it be exposure of information, whether it be availability of behavioral health as part of your health record. Those things can be applied in a global fashion, and to be clear, the very next request that comes through aligns with those new rules. And because you're using those external, being able to extract things like sub-processes and rules, it, again, helps everybody align to the same core process, allows for that flexibility, allows for also implementation regardless of what the particular local or regional constraints are. So you have that flexibility to be able to go ahead, and if you want to do this process in 5 steps versus 25, we can do that. As long as you achieve the core 5 that we need you to do, it doesn't matter, to be fair. And so that is the other piece from a governance standpoint, that we're able to also allow organizations to better align to ACO requirements, making sure that accountable care organization, KPPs, KPIs can be met. Being able to trace that back and provide that visibility, it all is supported and enabled by BPMN. And I would be happy to support another conversation where we can do a deep dive, because I think this is again the core of what we're trying to do under BPM Plus.
So I would also say a lot of members of this community also attend HL7, and BPM Plus is in early phase of conversation to potentially co-align in September. BPM Plus always provides an excellent tutorial and introduction to these tools with their sessions. And so would invite participation to join the BPM Plus community. It is a very technical community, but the work that's being done there is just amazing.
Well, and we have a ton of different, thank you very much for that vote of confidence, Mary. I sometimes feel that we're pushing the rock up the mountain. What we have been able to do since we stood up, and obviously, as I mentioned earlier, we have the Process Automation Implementation Working Group that Ben and I lead. We also have an authoring working group. We have an adoption working group. So we have a place where we bring in physicians, where we bring in actual clinicians to work on those processes that we saw at the very beginning, and then say, well, how are we going to make this work? How are we really going to test this out? And that's what our focus is within the automation implementation working group. But we are open to anybody. And I mentioned that before. Please join us. If you want more information, just feel free to reach out to myself, or Mary and Ed can obviously provide the links as well. And it's on the BPM Plus website that Mary put the link for that in there. You're welcome to join. We have every single working group has a meeting every other week. So we meet twice a month to focus and accelerate that in the case of HEMS. Where we were really kind of, heads down trying to make sure all of this worked together. But it's a very active group. Everyone's very focused, and we're looking at again, driving forward the standardization and capability that we've talked about today.
And to bring us back full circle, sandbox environment, standing up the communities of practice, really to complement the work that's happening in the standards organization. Very implementation focused on how do we actually take these standards, put them into action, provide venues under a community of practice that could be a public domain, open source, open access activity, but also being able to enable what we refer to as now things are meant to be done in the public domain. For instance, a state may want their own private instance or private locker where they can take the publicly available sandbox, the synthetic data, the de-identified PHI, can take that environment and basically have a hosted environment. They allow members they want to invite in, which third-party vendors they want to work with, which data they want to load into the environment, because Arizona may have a specific implementation. New York may have a specific implementation, and you may not want to do all this in the public domain, but you can leverage the wisdom of crowds in what's being developed by the community of practice for your particular needs.
Excellent wrap up, Mary. Thank you.
Yeah, this is very stimulating in terms of thinking about ways to address the complexity of the work we're doing, and particularly around the use case, Christine, that we're starting to really work on for just even trying to model that out and show where the the complexities come into play and where there are consents, there are no consents. I don't think there's a the advanced directive is a, well, I guess it's a different sort of end state. It's like, can I share my child's attendance record at school, under yes or no, or under certain conditions or whatever it might be. They're very
Daniel,
unique to
you
the
would
world.
get a kick out of if just a little work session, great way to learn the methodology. But if you had a work session to just talk through those different workflows and decision processes, they could be instantiated in these standards very easily. It's kind of a magical process. So, if we get to that point, maybe after another familiarization discussion, just going through that exercise with some of the experts on this call would be worth it, I think.
I would agree.
Absolutely.
I would agree.
Okay.
Great, everybody. Well, we appreciate the information. It's great to see it. I hope that we will encounter all of you, or many of you, or some of you, in the not too distant future. And we look forward to sharing the material if it's a shareable or when it's shareable. Mary and I can go back and forth on that. I know the community would love to be able to review it. And thanks for orientation to this really great, wonderful stuff. I'm glad I saw it the first time, and I'm more glad that we got to see it a second time. And with that,
In the meantime, be careful when swimming in the pond there.
yeah, right. Do.
And
All right,
thank you for the invitation to share this information, Daniel.
You
Okay.
bet. Thank you.
Thanks, everybody.
Thanks.
You.